Good afternoon, everyone. I want to welcome you today to the meeting of the Community of Practice on Evidence in Disability and Rehabilitation Research, also known as the COP on EDR. This is an activity of the Center on Knowledge Translation for Disability and Rehabilitation Research, or KTDRR, housed in the Austin, Texas office of American Institutes for Research. The Center on KTDRR is funded by NIDLR, the National Institute on Disability, Independent Living, and Rehabilitation Research. NIDLR is a center within the Administration for Community Living of the Department of Health and Human Services. My name is Joanne Starks, and I want to thank our COP facilitator and today's presenter, Dr. Marcel Dijkers, and Shoshana Rabinovsky, who is providing Zoom technical support. I'll now go over some of the elements of the Zoom environment. We are recording today's session for our COP members who are not able to join in today. If you prefer not to be identified in the recording, you can skip identifying yourself when you ask questions in the chat box. A copy of the presentation slides will be available once we post the recording on the COP private pages. You will listen to the event over your computer speakers, and if you need to adjust the volume, you can do that by adjusting the volume on your own computer, or click the audio settings on the left-hand side of the menu bar at the bottom of the window to open the audio settings section of your Zoom application. Please be sure to stay on mute during the presentation. In the center of your screen is the main presentation area where the presentation slides are being shared. You can access the chat box by clicking Chat in the center of the menu bar located at the bottom of the window. The chat box will then appear on the right-hand side of your screen. If you have any questions or technical issues, just ask in the chat box and one of the COP team members will respond. It's the best way to communicate with us today. KTDRR's Community of Practice focuses on the creation, evaluation, and utilization of evidence using techniques for systematic reviews and syntheses of high-quality research. In addition, the COP examines tools for the appraisal of systematic reviews and grading of evidence with an overall goal of increasing NIDLR grantees' contributions in the disability and rehabilitation fields. Some of you may be participating today as a result of your involvement in a 5-part webcast series presented last spring by KTDRR in coordination with the Campbell Collaboration. This is the first of 4 COP meetings scheduled for 2020, all taking place on the last Wednesday of the month in February, April, June, and the next to the last Wednesday in September. If we have time after today's presentation, we can start discussing possible topics and presenters for the next meeting to take place on April 29th. We'll continue that discussion by way of the COP listserv. If you are not on the list and would like to be added, just send me email at jstarks@air.org. So this afternoon, Dr. Marcel Dijkers will introduce the group to Tidier, the template for intervention, description, and replication. Tidier is a guide and reporting checklist that was developed by an international group of experts and stakeholders to improve the completeness of reporting and ultimately the replicability of interventions. This topic was suggested last year during a previous COP meeting. So please do ask your questions in the chat box as they come up during the presentation. So let's go ahead and get started. I'll hand it off to you, Marcel.
Thank you very much, Joanne, and welcome everybody for a session on a topic that at least I think was interesting, and I hope you will find it too. So if we can move to the first slide, this one. You may be aware that complaining about the quality of reporting on research, medical, behavioral, healthcare research, rehabilitation research is an old tradition. People are complaining about it because utilizing the fruit of research is made very difficult if the report leaves much to be desired. You will not be able anymore to tell the difference between poor research, which presumably was done on small samples, unreliable, not well measured outcome, biases in reporting and what have you, and good research that is worth replicating by other researchers or worth implementing by clinicians in their practice. And we can think of a worst case scenario where some rehab researcher does a research project that is really interesting, asks a good question, answers it with very good methodology on a large sample, and reports it so poorly that nobody has an idea what's going on, and it will never have an impact. Next slide, please. Well, once people started realizing that there was a problem here, they started developing what has become known as reporting guidelines, which tell researchers, which tell authors, what to write in their paper, how to write it, where to park it, what is absolutely needed for a particular type of research. And potential authors can use this checklist in writing their paper. Oops, I should put this in. Oh, I should put that in, but best goes in this section, not in that section. And some journals now, including almost all rehabilitation journals, require people to submit, when they submit a manuscript, a copy of the checklist on which they fill out what information is to be found where. Can we go to the next slide? Oh, next one. Here's, for instance, the beginning of the checklist of the what's called the consort checklist for reporting a randomized clinical trial, a randomized controlled trial, which has about 20 items. A 1A, in the title of your paper, identify this as a randomized trial. 2A, give the scientific background and explanation of the rationale. And you see the last column can be used to fill in on what page and maybe what lines on a page the information can be found. So a checklist like this may be required by the Archives of Physical Medicine Rehabilitation if you are shooting to publish your paper in the archives. Can we go back 2 slides now? Okay. So the first checklist were those for RCTs, and the famous consort was published in 1997. And it's consolidated because it already combines the efforts of 2 groups to develop a checklist. After consort was published, the same group or related groups produced what I call subsidiary consort standards. How to report for a specific study design, how to report for classes of interventions, etc., etc. Next slide. Now, this is a very active area of development. At the bottom of the slide, you see a reference to the Equator Network. The Equator is an organization that collects and lists reporting guidelines. And the last time I looked, they had 400 different guidelines. Now, there is what you may want to call the big 10, and those where you will find on the front page of the Equator website. Yeah, there's Consort, Strobe, Prisma, etc., etc. Some of these have extensions, others do not have them or do not yet have them. Next slide, please. And we saw this, so let's move on to the next. Now, pretty soon, after Consort was published, people realized that it wasn't really very informative for people who do research on complex interventions, including rehabilitation. Consort has a statement, describe the intervention and the comparator. That's all you're told, which may be easy to do for a drug versus placebo trial, but if you have developed a new program to help people with traumatic brain injury in anger management, there is not a single formula you can give them and that does the description. So pretty soon after Consort was published, a group developed Consort NPT, which is Consort for non-pharmacologic trials, published in 2008 and published in 2017. And even that didn't work out all that well, and then updated group developed something called the Template for Intervention, Description, and Replication, TIDIR. And TIDIR was published in 2014, and it aims to give guidance for all those interventions that are beyond the simple pill versus placebo. You can call it and consider it supplementary to Consort, and if you would do so, you would knock out that one very limited Consort instruction and replace it by the 15 elements in TIDIR. Let's go to the next. In the rest of my talk, I will have to make a distinction between interventions and comparators. And intervention is what we used to call, maybe still call, the experimental treatment. The independent variable which is studied as a possible causal element in bringing about better patient outcomes. And in high-quality research, the results of an intervention is compared to the results of what nowadays is called the comparator, also still called the control condition, which can be weightless control, a placebo, it can be usual care, it can be the standard of care, it can be the most successful existing treatment. But you have to realize that the comparator, except maybe in weightless control, is an intervention itself. It would be very confusing to talk about the intervention and the comparator intervention. So I try to use the word intervention and comparator. In RCTs, there is at least one intervention. There may be more, and there is one comparator. There may be more. And before and after studies, there is no comparator. The pre presumably was the time that the subjects either got no treatment or not very good treatment. The post is after they got the experimental treatments, and there's a comparison. Next slide, please. Let's focus in on Tidier. It was developed by Dr. Hofman, who's in Australia. If you follow at all clinical research methodology, you will recognize the names Glasio and Boutron and Moher and Altman and Johnston and Chan and Michie. So this was some heavy hitters who developed this and published it in the British Medical Journal in 2014. And they expected that letting Tidier loose on the research world would improve the reporting of interventions and make it easier for authors to structure accounts of their interventions and for reviewers and editors to assess those descriptions and for readers to use that information. And we can only say, yeah, that's what we would hope that would happen. Tidier consists of 12 items. Next slide, please. Here's 1 through 4. I will try not to read these and to spend too much time on them. Number 1, give it a brave name. 2, why do you administer the intervention? What's the rationale, the theory behind it? Number 3, what materials do you use? And it can be drugs, it can be plasters, it can be pieces of paper for use by patients to understand stuff. It can be lots of stuff. Number 4, the procedures. What are the steps that you use in your intervention? What do you do with the patients using those materials? Next slide, please. Who provided in your research? Who delivered the intervention? What was their training, their background, their expertise, and for this particular project, did they get any specific training? Number 6, how was the treatment delivered? Face-to-face, telephone, internet, was it individual and or group? Number 7, where did this treatment take place? A hospital, a patient's home, outpatient clinic, you name it. Number 8, when was it delivered and how much was given? Did it a month? Did it take 2 months? Was there 1 session a week? Were there 5 sessions a week? Did they last half an hour or 2 hours? All that kind of stuff would go here. Next slide. Number 9, tailoring. If not every patient got the same stuff, but it was tailored for the patient, like with drugs where you can get micrograms per kilogram body weight. Then describe how it was tailored, why it was, what were the rules for who got how much. Number 10, modifications. If halfway through your study you changed the treatment, let us know what was changed. In any and all of the steps listed above. Number 11, how well was your treatment planned? If you assessed intervention adherence, treatment fidelity, describe who did that, how it was done, and what strategies did you use to maintain or improve fidelity with either your treatment deliverers or with your patients. And number 12, report how well did you achieve the fidelity? Yeah, how closely was the treatment delivered parallel to what was the plan for the treatment? Next slide. Okay, so as I said, yeah, these checklists, including Tidier, are primarily used to help people write better papers. But very soon after the first one were published, people said, you know, this checklist can also be used as a method to measure the quality of papers. Yeah, we can take this paper, look at checklist item 1. Yeah, did they do this? Yes, no, or did they do it completely, somewhat, not at all? Yeah, ditto for item 2, etc., etc. And then, of course, you can count the number of yes answers, and that's an indicator of the overall reporting quality of the paper. Rehab intervention description that gets 0 Tidier points is a very poor description. One that gets 12 points on Tidier presumably is an excellent way of describing the interventions. So people started to look at the quality of reporting overall, or before versus after the publication of Consort. And not surprisingly, people started to do this with Tidier. Next slide. So, the moment I happened to notice people were doing this, I pretty much, on an informal basis and later more formal, started to look at, okay, who has done this? Looking at primary papers, the original research, and writing a review article where they reported on the Tidier points they have handed out. And I looked for papers, for reviews that reported the scores, X% had good reporting, Y% had poor reporting on each item. I also looked as to did people give Tidier points separately for the intervention and the comparator, and did they do it by the information sources that they used, and we'll get there in a minute. And I'm trying to now draw conclusions on the quality of reporting in rehab and make some recommendations. Next slide. So here's my methodology. I searched for these papers in the time period from 2014, when Tidier was first published, through the end of last month, looking in 5 databases: Medline, Ambus, Web of Science, PsycInfo, and CINAHL, for the title or the abstract to have the term Tidier or the expansion template for intervention, description, and replication. I looked at all the abstracts. Is this a paper that seems to have done a description of primary papers using Tidier as a rating tool? If so, I got the full text to confirm that, and to look at were there actual item level results reported. Extracted the information either from the text, from the tables, sometimes from graphs, and also from SDC, supplemental digital content on the journal website and put all that stuff in Excel files, combine them and analyze them using SPSS. Next. I extracted, what area of rehab, is being covered, what study designs were the review articles looking for in the primary studies, what years of publication of the primary studies, what number of studies did they have, or more specifically, how many study arms did they have, because one primary paper can have 2 or more intervention arms and 2 or more comparator arms. And I looked very carefully at, are they evaluating just the intervention, or did they look at intervention and comparator, and did not very clearly specify this. Next slide. And I looked at information sources. Some of these review papers just looked to find whatever was published on physical therapy for people with stroke, and found all the papers that were published, looked at the ones that indeed talked about interventions for stroke, and assessed those. But other papers, in addition, went, well, there's information missing here, but oh, look, this paper here refers they published a protocol. Let's look in the protocol whether they have a better description of what the intervention is. Or they published another paper on that looks like a subgroup of these people with stroke. Maybe they give a better description in the other paper. So I will shorthand this to be additional relevant papers. And then there were some people who went a step further and said, well, even if I use the additional papers, I still had so much missing information in my tidier items. I'm going to ask the authors to fill in this information. And they sent out emails to the authors of the primary papers. Can you tell me what exactly was the training that you provided for the people who delivered this intervention? So they tend to report this separately and cumulatively. So let's take this hypothetical PT papers. They had PT review. They had 40 primary paper. Using the index paper only, they might have said that tidier item X was completely reported for 25%. Then if they went and searched for additional papers, they took that information into consideration and might come up with now item X is completely reported for 30%. And after they did emailing and got more information from the authors, they might said, well, we now have complete information for item X on 43%. Next slide. Of course, I got a number of tidier items used, the supplementary items created by the reviewer. I would guess about a third of these papers said, well, the tidier as written by Dr. Hofmann et al. Is a little bit too wide. If we want to know how to replicate, say, an exercise intervention, we need to know the following. How many times a week, how many hours each time, what intensity of exercising. I need 3 specific sub-items. And the same might be done for item 3, materials. So I identified these, what I call supplemental tidier items. I looked at the rating categories. Most people just had a yes versus no, but there were some who said there's a yes, there's a partial, and there is a no. I looked at whether they used not applicable for all items or for some specific items. I looked at what criteria did they use for yes, which may be such things as sufficient for replication or completely reported. Are those two different? I don't know, but to be sure, I just collected that information. And when these papers, looked at, the quality of reporting over time in these primary studies, I looked at what their conclusion was, or their finding relevant to the longitudinal improvement. Next slide, please. Okay, last methodology. I put everything, as I said, in a database. I had for each paper up to 6 arms. It could be the intervention only or the intervention and the comparator. It could be the index paper only or the index paper and the additional papers, or the index paper, the additional papers, and the email. So that's potentially 6. Most of these papers had only one series. As I said, taken from table text graphs, recording, not applicable, unknown, partially reported, partially to simplify stuff. I made the 0, the same I did with not applicable, question mark, unknown. I realized, I reasoned that if you as a reviewer, write, did this primary paper report everything that you need to know on item 5, who, and you write in, I don't know whether they report everything. My reasoning is, no, they didn't report everything there is to know, because otherwise you would have said, yes, they reported everything. Okay, let's get into some of the results. Next slide, please. I found 34 reviews that appraised from 3 to 287 primary studies. And here are some of the topics of these reviews that I consider to be pretty much representative of the 34. Cardiac rehab, skin self-care management in spinal cord injury, exercise for knee, exercise for arm, psychotherapy to promote adherence to therapy. Very interesting topic. Repetitive transcranial magnetic stimulation for major depressive disorder. Pelvic floor muscle training. The gamut of rehab topics. Next slide, please. The results, most of these papers only looked at RCTs. 7 of the 34 looked at RCTs and other controlled trials. And then there were 4 that took any design, including pre-post, and some even qualitative research. The years that were being looked at, the earliest year of any primary paper in any review was 73, the latest was 2019. The average number of years covered was 20 years, and that ranged from 1 to 42 years. Next slide. Okay, I told you that most of these reviews only looked at the interventions. A minority also looked at the comparator. So there is the intervention row and there's the comparator row. These are not different studies. Yeah, all the comparators were in primary research that also looked at the interventions. The reviews each had a number of arms, so between those 24 reviews, the reviewers looked at a total of 1,362 arms. Now, as I said, most of the time, if people looked at additional papers, they also did looking at the index paper only. So in the blue cells, everything there tends to be, not by definition is, but tends to be also covered in the green cells. And if I tell you that there were 34 studies altogether, and the green cell here has 24, that means there's an additional 10 studies that are in the blue cells. So 5 of those are duplicates with the green. And the same for the even less frequent yellow cells. They tend to be the same studies that were in blue or were in green. Next slide. Okay, we finally are there. Here is the result of the studies, and I picked just 5 reviews that reported on all 12 items, which happened to be 323 interventions. So you can see that a name for the intervention and why it's delivered is pretty much delivered or found in every primary study. But look at T10 modifications. That's less than 10% of studies tells you whether or not there was modifications, and if there were modifications, exactly what they were. And all the other items pretty much fall between about 35% and 65%, which means there are lots of papers that fall short reporting all the information that tidier things you need to report. Next slide. Now I looked at intervention arms and comparator arms, and this was based strictly on reviews that reported on both. They not all had 12 items that just did not happen. These were studies that used just anywhere from 7 to 11 items. But look at the difference between the blue, which refers to this complete description of the intervention, and the orange, which is correct, complete description of the comparator. And it's not hard to see that the description of the intervention is almost always better, probably much better in all 12 items. And if you look at T10, were there modifications? None of these studies describing comparators did a good job there. Next slide. Let's look at what happens if you use different sources of information. You can see that if you just use the index article, the original paper, you get the blue lines. If you roll out additional sources of information that are publicly available, the orange line, you get a nice improvement, for pretty much everywhere between T3 and T12. And if you, in addition, start to email authors, what did you do? How would you describe? Can you tell me? You get another bump, very often a nice bump. So for T1 and T2, it doesn't make much of a difference, mostly because there's so little space to grow there. But look at T3. If you ask by email, what were the materials you used, you get so many good answers that you pretty much double the percent that has an adequate description. And for T6, there is a big increase. For T10, there's an increase. Generally, there's a good payoff, from emailing. Next slide, please. Let's look at some of the sub-items where people split up and standard tidier item to make sure that whatever they considered important in a description of an intervention, that information was reported. So there was Abel, which was an exercise, I think this cardiac rehab exercise. She said, we want to know about exercise intensity, session length, exercise frequency, and overall program duration. How many weeks or months. Baron, which was about spinal cord, skin, self-care. She wanted to know what materials did you use for the participants and what did you use for the providers. Next slide. Bartholdi, she picked a large number of elements that she considered to be relevant to exercise interventions. Was it individual or group exercise? Was it supervised or not? Did you just tell patients go home and do your exercises, or was there supervision? What was the content of home programs, etc.? Let's look at Yamato 2016. For the how, he insisted on separate reporting of the mode of delivery, in-person, telephone, computer, and whether it was individual or group. Next slide. Okay, well, let's go to some conclusions. First of all, realize that the quality of the research and the quality of the research reporting are not the same. There has been some research done, and we know that even the best researchers sometimes shoot themselves in the foot by not reporting what readers consider to be very important information. Like, did you blind the therapist? So presumably there's just a weak association between the quality of the research per se and the quality of the reporting. But we want to improve research quality, and we want to very much improve the quality of the research. The funny thing is that rehab researchers and other researchers tend to pay a lot of attention to the reporting of the outcomes. What did we measure and how did we measure it and how valid was this measure, etc., etc., and hardly say anything about the interventions. What did you do, when and where and how to make a change in the functioning of your patients? Well, this overview using Tidier just looked at the interventions, and it pretty much came up with the finding that intervention reporting in rehab is generally poor, except for a few elements that tend to be 1 and 2. What was the name for this treatment, and why did you give it? What was the reason? Next slide. Other than those two, adequate reporting is found only for 35 to 70%, even lower for modifications. It looks like a lot of people could help themselves by just putting in their report there were no modifications. We're not used to doing that, but maybe we should. Because then any reviewers and any readers will know for sure that they didn't miss anything. Next slide. The comparators are reported even poorer, if it's possible, than the interventions. Only between 25% and 75% of the percent that is gotten by the interventions. And the rehab researchers seem to forget that you can only judge the success of an intervention by looking at the success of the comparator. And in the end, we judge relative success by outcomes. But if you find that the treatment is only marginally better than the comparator, is that because you hardly administered enough treatment, or because you gave such a beautiful, strong comparator? So we need to know that. Next slide. Yes, finding additional literature or sources of information helps. Contacting authors helps even more strongly. And nowadays nobody should have an excuse anymore for not writing complete detail on an intervention, because we now have supplemental digital content. And no journal puts a limit on how much you put in files that go on the website. So you can give a complete report. Okay, now as I showed, about a third of the reviewers created sub-items within Tidier. And that suggests that these Tidier items, as they're currently written, are not specific enough. Even though they just do splitting, apparently reviewers want to have very specific information reported depending on what type of rehabilitation research they are considering. With John White, whom some of you may know, I've been working in an ad hoc group of the International Society of Physical Medicine Rehabilitation to develop a reporting guideline for rehab research. And what we did is we went to the Equator website and from there got 150 reporting guidelines that they classified as being relevant to randomized clinical trials. Next slide, please. And we looked at all the information with respect to the intervention that these various guidelines suggested people follow. And one conclusion that we indeed drew was that TIDIA can be more specific by including sub-items. However, we should very much be aware of the fact that what useful sub-items from one area of research are not very much of help in another area. And look at just or consider just cognitive behavioral therapy for depression, teaching cathing after spinal cord injury, cardiac rehabilitation, exercise, and even something as simple as prescription of medication and teaching of caregivers of, say, somebody with severe stroke and spasticity. We pretty much came up with the conclusion that a treatment theory underlying an intervention, which is essentially a statement of what ingredients affect what specific outcomes, targets of treatments, how. Once you have a treatment theory, it will guide you toward what is relevant to report or not. Next slide. So we have essentially three options for making TIDIA more useful. Keep TIDIA with some limited tweaking of items to make them optimal for rehabilitation. And I must say, if you look at the text of the Hoffman article, there is a lot of good stuff in what tends to be called the elaboration. The examples and the why of the items. But if you just harvest the items by themselves, all of that disappears. We could try to create one single TIDIA for rehabilitation, but it probably would have 200, if not more, sub-items. And of course, if there's a checklist with 200 items, nobody's going to use a checklist with 200 items. They want go back to the original TIDIA. Or we could try something like creating 20 specific rehab TIDIAs, each one optimized for a specific area of research as in CERT. And what is CERT? Next slide, please. CERT is a reporting guideline for exercise. And they have, I'll show you on this slide and the next, a whole bunch of items that they consider to be essential to be reported if you're describing an exercise treatment, including such interesting stuff as number 6, a detailed description of motivation strategies. Number 9, what's the home program component? Next slide, please. Of course, there is a detailed description of the exercise intervention, but then there's also number 14, is it generic, one size fits all, or tailored? And if it's tailored, how? Number 15, the rule for determining the starting level for a person. And where is that? It's somewhere in here. The rule for progression, to make the exercise, more intensive to the degree that the patient involved, becomes stronger, starts doing more rotations, walk more meters or miles, what have you. So this is an option for a group of people to look at what do we want to see for rehabilitation research in a particular area, and can we develop a tidier version that is specific to that. So you just would have to read to a list of, let's call it 20 modifications of tidier, pick one. Oh, that's what area of research I'm reporting on, and then follow those specific instructions for describing. And next slide, please. Of course, it creates new problems. Who's going to determine what is the optimal approach? One of those three. And if we pick option number 3, multiple tidiers, who's going to decide on how many different tidiers do we need, and how many sub-items of what nature in each area are optimal? And if we develop 20 tidiers, it would be very good that they more or less follow the same pattern. So we have to make sure that all the 20 groups that work on implementation stay in sync. And we already have the issue. There are too many reporting guidelines, and Equator doesn't even have the complete count, but they're pretty close. And they're 421. And as I said, too many guidelines with too many items, optional or not. Nobody will follow it, and people will just go back to the tidier as it exists. And hopefully we'll remember that they should describe the intervention and the comparator. Next slide, please. Rehab is a complex intervention. It is not simple to describe all the interventions, or a single one and its comparator in such a way that all the ingredients are described complete with dosage. The readers can understand the descriptions. The clinician educators can teach them. The clinicians can implement them. The systematic reviewers can classify them. And the researchers can replicate and extend them. We ask a lot of things of description of rehabilitation intervention study, but it has to achieve all those things, and probably those 5 categories of readers, of users, don't have that different expectations. So one well-written intervention will serve all 5 or 6 of them. We have to do a better job than we have been doing. And if you're a clinician or an educator or a researcher or a knowledge translator, you have to insist that the researchers write better, or else nobody can use the research results and write better, not just the intervention, but also the comparator. Next slide, please. I'm open to questions. Thank you very much.
Well, thank you very much, Marcel. And it looks like we're actually out of time today. We don't have time for any questions. So we'll need to follow up on our listserv with some ideas for our April 29th session so that we can identify a topic and identify a speaker for that next Community of Practice meeting on April 29th. And then we'll be following up in June 24th, with the final results from using the Agreed To tool to evaluate the quality of rehabilitation clinical practice guidelines. This study that was carried out by a subgroup of the Community of Practice, the overview and steps in the study were presented last year at the September meeting. We'll have the results available then in June. And then September 23rd is tentatively scheduled for an update on the tool assessing the quality and applicability of systematic reviews, or AQASR, that was developed about 10 years ago by some NIDLR-funded disability and rehabilitation researchers. We did have one question that I don't have the exact wording on, but it was from James, and really it was looking at your results and saying that even with the use of Tidier, should we be worried about the quality of the research itself based on the kind of sketchy outcomes that you got in doing this review?
Yes, we should. Yeah, always have a healthy level of suspicion as to what people did in their research. Yeah, whether they do not describe it at all or describe it in such summary fashion that you cannot understand it, or describe it confusingly, and all those things. Today I focused on describing the intervention, but yeah, we could do very much a parallel session on other segments of the consort statement. Doing research is not easy. Reporting on research isn't easy. Presumably we will get better over time as we learn more, as we get these reporting guidelines. But what I have seen, the improvement is slow. So I would encourage all the rehab researchers to use Tidier and other guidelines. And people who are research result users may take Tidier at hand and look at a report and say, okay, if I wanted to do this treatment, do they tell me this? Do they tell me this? Where do they tell me what are the materials? And all those questions that are covered, maybe not perfectly in Tidier, but that will help people establish that they at least have enough information they can start implementing treatment or replicate a treatment. So, yes, research seldom is perfect. Research reports seldom are perfect. We need to have healthy skepticism, but also, I believe that certainly with some impact by email from the researcher, we can come up with information that makes a research report more useful to our practice. So that's my in short answer, which is a long one.
Well, thank you very much. So thank you again, Marcel, for your presentation. Thank you to Shoshana for the logistics, and to NIDLR for supporting the activities of the Center on KTDRR. So please be ready to discuss some topic ideas as we follow up on our COP mailing list, and we'll let everyone know when the recording and slides are ready as an archive.